Welcome everyone to this presentation on the drugs we use to treat cancer. My name is Pamiz Alibai and I'm an oncology hematology pharmacist at Emory Johns Creek Hospital. I'm realizing that there's too many Emory logos on this slide. So starting off, I do not have any relevant conflicts of interest, unfortunately. By the end of this presentation, I would like for participants to be able to identify the major categories of oncolytic drugs we use, describe the mechanism of action for these drugs, recognize common adverse events, and then identify key adverse effects that can affect a patient's ability to undergo physical therapy. So we're going to start off with a flash review of cancer, and then we're going to review our common oncolytic agents by traditional chemotherapy and then targeted therapy, and then we'll go over key toxicities. So cancer is our uncontrolled growth of cells due to a defect in the normal cellular processes that can originate anywhere in the body and spread to other parts. So this is just a quick recap for any of our colleagues that don't work with cancer patients. And you'll see on that figure on the top part, we see normal cell division, right? So our cells go through many generations of replication, and over time, they will start accumulating or coming across mutations. When these mutations occur, our cell has these checkpoints and safety measures to catch the mutation and then either kill off the cell or let it continue. We can see that in cancer cells, you start accumulating these mutations and the cell loses its ability to stop the mutations and kill off the cell, or apoptosis. And cancer can present with a lot of side effects, very characteristic side effects such as weight loss, night sweats, but then you can also have asymptomatic, incidental findings of cancer. So the staging for cancer varies mainly based on if it's a solid tumor or liquid tumor. We're just going to cruise through this part, but solid tumors, we care about the tumor size, nodal involvement, and then the presence of mets. And then for liquid tumors, we don't follow the same classifications. So we care about things like where did it start from, what type of cell, what is the maturity of the cell, and then where is it spread to? So do you have extranodal involvement? Do you have bone marrow involvement? So it's a little bit different for our liquid tumors versus our solid tumors. So here we are at the whole entree of our meal. So the chemotherapy drugs we'll go over first, and these are the different classes of it, and then we'll go over targeted therapy. So you'll see that this same lecture can be presented, and you can classify these drugs in many different ways. The way we're going is first our non-selective or less selective, then our more selective. And then we'll go into our small molecules versus our large molecules. So going into our traditional chemotherapy, you see on the bottom the timeline of a single cell going through the different phases of mitosis. So you have the general mechanism for chemotherapy is that we want to impair the process of cell replication to reduce proliferation and kill the cancer cells. And chemotherapy is relatively selective for cells with higher metabolic rates. So these very hungry cells, like tumor cells, will take up more of the chemo from the blood and be affected more by it than our normal healthy cells. And then chemotherapy can also be looked at where it affects the cell. Is it dependent on the cell being at a specific cycle, a stage of the cycle, or is it independent of where the cell is? So is it non-cell cycle specific? So starting off, we have our G0 phase, which is not shown here. And that is just the resting phase, very little metabolic activity. And cells can spend a long time in this phase. They can be there for years. And then we have G1. This is when our cells will start to grow and prepare and make more proteins. And this is, we'll start going into DNA replication and preparing for the division that is to come. And then G2 is when it'll start getting everything in line, making sure everything is okay, doing some checkpoints, lining things up, cleaning up the DNA. And then mitosis is when the cells will line up and all the DNA into its nicely packaged components and then divide and properly allocate each cell to have an equal amount of the DNA. And so normally you have these daughter cells. And so this is just going on one by one into each of the phases. Now, normally you'll have this nice division and the cells can keep undergoing replication. Over time, they'll develop mutations and then they'll kill themselves, or apoptosis. But cancer cells, they develop these mutations, but they don't kill themselves. They keep differentiating. So you'll see the cancer cell actually has this, disproportional allocation of the DNA, where one side got a lot of things and the other side didn't get that much. So this is another depiction of the cell cycle, but this shows where the drugs work on it. So starting off on the green with G1, we see that actinomycin works on cells in that stage. And then going to the yellow with synthesis phase, we see our antimetabolites are very effective on that stage because that's when the DNA is made and replicated. And then you have topoisomerase inhibitors in the growth phase, which work on the enzymes that are involved in, and you have salmon inhibitors, which will depend on microtubules for the cell to undergo mitosis. So if you inhibit those, then you can cause the cell to die off. So that is the section where microtubules work, inhibitors work the best. On the bottom right, you will see cell cycle independent drugs. So these, they will work on the cell regardless of what stage the cell is at. So chemotherapy, the general mechanism of toxicity is that even our own normal healthy cells that divide more rapidly, they will also uptake this chemotherapy. So we have a lot of collateral damage. So cells of the GI tract, so you get mucositis, diarrhea, and then hair, people's hair falls off, it thins. And then bone marrow, which are cells that are very highly proliferative, they'll be affected and you'll get myelosuppression. So we also look at dose-limiting toxicity. So when these drugs are initially studied, we make them go through, we have a small sample of patients, maybe 3 patients, 5 patients, and you increase the dose to see what toxicities occur and when does it become intolerable. So the dose-limiting toxicity is the dose at which a toxicity was so great that you couldn't increase the dose anymore. So some types of dose-limiting toxicities can be myelosuppression, veno-occlusive disease, nephrotoxicity, neuropathy. On the right, we have this nice figure called the anti-neoplastic man, or the chemo man. And this is a nice way for pharmacists and anybody working with oncology medications to kind of remember the toxicities to expect. So bleomycin causes pulmonary fibrosis. So you see a big B on the lungs of our chemo man. So just a fun way we can remember the drugs. So our first class is a big class and was discovered really around World War II time because of its war capabilities. But we find out that also it's very good at killing cells. And these are the alkylating agents. So alkylating agents, what they do is they alkylate. So they form these covalent irreversible bonds in between base pairs of DNA. So you'll see in the figure to the bottom right, one of our alkylating agents, carmustine. And what it's doing is it's forming these bonds between guanine base pairs of DNA. And that, of course, messes up the DNA's ability to be tightly packaged or rewound or even replicated. So that causes cell death. And of course, if you can affect the DNA, you can affect it at any stage of the cell cycle. So that's why these are non-cell cycle specific. So this is the common template we'll follow for drugs. We're going to cover 100+ drugs. So on the left column, we have our bold-faced drugs, so busulfan, thiotepa. And then the middle column, we have our indications. So these are the most common indications. There's going to be some indications I haven't included. And then key adverse effects. So busulfan, used for bone marrow transplant. The key adverse effects are veno-occlusive disease, which is a dose-limiting toxicity, mucositis, seizures. And then I bolded some notable toxicities that may be more relevant for physical therapy. So this patients can develop pulmonary fibrosis. It's more common than we'd want it to be. So if a patient presents to you and they're having difficulty breathing, progressively, then you can start suspecting this patient might be suffering from pulmonary fibrosis related to busulfan, and then you can catch it before the oncology team catches it. The next drug is thiotepa. Thiotepa is not very commonly used. It's very unlikely that you'll see it very often, but it's used for bone marrow transplant, and big toxicity is myelosuppression, as is a very common toxicity of alkylating agents. And I've highlighted myelosuppression for drugs that we'll cover because myelosuppression can present as leukopenia, anemia, thrombocytopenia. So a patient with a low white count will be at high risk of infection. So you might catch a patient who is showing signs of infection like a fever, and it'll be important for us to work that up to make sure that it's treated because patients will have a weakened immune system. Patients can also have thrombocytopenia, so they'll be more likely to bruise and have bleeding. So we want to be cautious for that when they're undergoing their physical therapy. And then anemia, patients will be more fatigued, they'll have more shortness of breath. So these are things that you can easily notice before their oncologist notices. So I won't go deeper into temozolomide, dacarbazine, and bendamustine, but they are here on the slide for reference. So we have cyclophosphamide and ifosfamide, which are sister drugs, and they have very broad series of indications they can be used for, but we can see again, myelosuppression is a very common theme for this entire class. And I really won't go much deeper than that, but you can see that myelosuppression, hypotension, and diarrhea are common toxicities, as well as nausea and vomiting. So I gave platinum analogs its own special slides because even though they are under the class of alkylating agents, which is under the class of traditional chemotherapy, these drugs all have this special platinum moiety. And that's a key characteristic of these drugs because they'll all have this platinum group, but they'll also have different side chains, which affects where the drug will bind and some of the side effects we can expect with it. So cisplatin, carboplatin, oxaliplatin are the three main ones in common practice. So these three drugs, they have a lot of indications, are very commonly used. And the big common side effects they carry are nephrotoxicity, peripheral neuropathy, nausea and vomiting. So for peripheral neuropathy, patients can develop it as they get more cycles, and they'll have this tingling sensation in their fingers and toes of their extremities. And it can get to the point where it's debilitating, where patients can't even button their shirts. And also we see myelosuppression as is a common effect of alkylating agents. And then oxaliplatin has a notable side effect of this cold sensitivity. So when a patient is getting oxaliplatin, I warn them that don't drink cold fluids or eat cold foods or touch cold things for at least 48 hours after the drug is administered. But as patients get more cycles, the cold sensitivity can take longer to reverse. So that's just something to keep in mind. Then this next class of drugs is our anti-tumor antibiotics. So these drugs can be classified in many different ways. I chose to classify this group based on how they were discovered or how they're isolated. So this class of drugs includes drugs that have different mechanisms, but they're all isolated from a strain of the Streptomyces bacteria or different strains of the Streptomyces bacteria. So the drugs in this class are bleomycin, and then we have anthracyclines, which have a lot of agents, dactinomycin, and then mitomycin. So these are called the anti-tumor antibiotics because they are anti-tumor effect and they come from bacteria. So this class of drugs has 4 different mechanisms that they share, and anthracyclines will actually show components of all 4 of these mechanisms. So we see topoisomerase inhibition, and we'll cover more about that in the upcoming slides. But DNA intercalation, so what we see is that the drug inserts itself between adjacent base pairs of DNA, and this inhibits DNA and RNA synthesis. And then we also get the production of excess of reactive oxygen species. So when you have too many of these reactive oxygen species, your body isn't able to reduce them, and they oxidize DNA, which leads to DNA damage, lipid peroxidation, and then which leads to cell apoptosis. So bleomycin is notable for that. Okay. So we have our anti-tumor antibiotics here. And again, the left column is the drug in bold. And then the middle, you see that there's a lot of indications specifically for the first row of drug, which is anthracyclines. And then on the right, you'll see our class adverse effects. So cardiotoxicity is notable for our anthracyclines. We will check a patient's heart. We'll do an echo. If the EF and everything is okay, then we will continue. and they will observe periodically. If there's issues, then we might not even use the drug at all, or we might monitor more closely, or we might give them another agent that is cardioprotective from the toxicity of anthracycline. So big thing to remember is a cardiotoxicity. And then these drugs, let me go a slide back. You see on the top right, doxorubicin is very red. So all these rubicin drugs have this red tint to it. So patients who receive this drug for the first 24, 48 hours, they might excrete it in the urine and stool. So I warn patients that don't be concerned about it. It's normal. It's just going to be a light pink dye. It doesn't look like bright red blood would look. And of course, myelosuppression is very big for these drugs. Myelosuppression, it can take 3 weeks for a patient, or 4 weeks, or even longer for a patient's bone marrow to recover after some of these drugs. So we talked about topoisomerase inhibitors within the class of anti-tumor antibiotics. So this is drugs that are topoisomerase inhibitors, but they didn't come from that bacteria strain. So these are our topoisomerase 1 inhibitors like irinotecan and topotecan, and then topoisomerase 2 inhibitors, which includes the anthracyclines, which we talked about, but also etoposide. And topoisomerase is an enzyme that cleaves DNA, either a single strand cleavage or a double strand cleavage. And then this is important because DNA is so tightly wound up. You need to open it up so you can gain access to it. Then once you've got your access to it, then you need to religate it. So these drugs, they inhibit the activity of topoisomerase, the enzyme, which leads to irreversible single strand or double strand breaks, which leads to the cell dying off. So the toxicities for this drug, irinotecan, very notable toxicity is diarrhea. Some people call it I run to the can, and patients will keep that in mind that when you get irinotecan, so I've had patients who immediately have diarrhea. So we do give them some medications to help reduce that, but the symptoms of diarrhea can persist for 2 to 4 days, sometimes even longer for patients. And then myelosuppression is very big for these patients. So antimetabolites is our next class. So we finished alkylating agents, anti-tumor antibiotics. Now we're on antimetabolites. So these are antimetabolites. So they inhibit these metabolites needed for DNA synthesis. So you'll see in the bottom right the molecular structure of these different drugs that mimic components of DNA, are these nucleic acids. So they can either mimic our pyrimidines or they can mimic our purines. Or you'll see on the right our dihydrofolate reductase inhibitor methotrexate, which is actually, I think, one of the coolest drugs. And if I was asked in the interview what my favorite chemotherapy drug, I would say methotrexate. And these drugs work in different ways. Generally, they'll mimic these nucleic acid components being incorporated into the DNA. Then the DNA won't be able to properly read and replicate it, and the cell will die off. They can also inhibit the enzymes needed to replicate DNA. So this slide has a lot going on. Just follow with me. We're just going to go very superficial on this slide. So on the top, you'll see on the left side is pyrimidine synthesis. The right side is purine synthesis, right? So these are types of nucleic acids used to make DNA and RNA. So a common precursor is the ribose 5P on the top. So starting off, we have our 5-fluorouracil and capecitabine. 5-fluorouracil is also called 5-FU and pemetrexed. So these inhibit thymidine synthetase. So they inhibit enzymes from making thymidine, which is a pyrimidine. And then we also have the middle side, which is our folic acid inhibitors like pemetrexed and then my friend methotrexate. And then further downstream, we have other antimetabolites that will mimic nucleic acids like cytidine and like gemcitabine, fludarabine, cytarabine. And some of them will also inhibit DNA polymerase. So then DNA can't be made, RNA can't be made. And so these are some of the ways these drugs will work. So this is a list of all the common antimetabolites. You'll see myelosuppression is a very common toxicity of these medications. And then you also have some dose-dependent toxicity. So for cytarabine, if you're treating, AML and ALL, you might get to this high level of dose where you start seeing neurotoxicity. But at lower doses, like we use for intrathecal agents, then it's less likely to see neurotoxicity. And then you have drugs like gemcitabine, which cause flu-like symptoms. You have my friend methotrexate. So a little bit of HIPAA here. My grandma uses methotrexate. She takes 15 milligrams once a week for rheumatoid arthritis. For our patients with ALL, including the young kids with ALL, we give them sometimes 15,000 milligrams of methotrexate. So that's 1,000-fold range. So that's how versatile this drug is. And methotrexate was actually like one of the earliest drugs we've discovered. So that's enough about methotrexate. But methotrexate, of course, causes myelosuppression, nephrotoxicity, and mucositis that is very bad. And then we have a newer antimetabolite, trifluridine and tipiracil, which has this added component of an inhibitor that prevents the breakdown of the key drug. So that lets it hang around longer. But then again, you get more myelosuppression. So we have cladribine, fludarabine, nelarabine, pentostatin. And then capecitabine and 5-fluorouracil is easily one of the most common drugs we use to treat cancer. Definitely one of the most common chemotherapy agents. Anybody who has GI tract cancer is very likely to be in one of these drugs. So these drugs, they are antimetabolites. Myelosuppression is very significant, as well as diarrhea, nausea, vomiting. Then you also get this hand and foot syndrome, which I'll talk later in this presentation, as well as cardiotoxicity. So next we have our microtubule inhibitors. This is another class of agents within the big umbrella of chemotherapy agents. And they disrupt microtubule formation, either by preventing the formation or preventing the disassembly. And when you do this, you arrest the cell at the mitosis or synthesis phase, and then the cell will die off. So you see on the right, this nice, picture of the green is the microtubule fibers, and you can see the two ends, polarized ends of the cells, pulling apart the cell and the DNA content, so it's equally distributed. So it's very important for microtubules to be lined up and properly, allocate the components of the cell. So we have two notable classes within this class, the vinca alkaloids, and which were discovered from the periwinkle plant, and then we have taxanes, which is discovered from the yew tree. And vinca alkaloids prevent formation or polymerization of these different tubules from coming together and making microtubules, while taxanes prevent the disassembly. So microtubules need to be able to freely made, to be formed and taken apart as needed by the cell. So if you prevent the formation or the ability to take it apart, then you don't get proper mitosis. So the key agents is really the taxanes and the vinca alkaloids. The other agents are used, but nowhere as near as our taxanes and vinca alkaloids. So taxanes, they have that root, the taxol, docetaxel, cabazitaxel, paclitaxel. And these are notable along with the vinca alkaloids for peripheral neuropathy. Taxanes also cause myelosuppression, and docetaxel specifically has a side effect of peripheral edema. So we give patients steroids a day before, a day of, and a day after to help reduce that edema. So you might have a patient that comes to you who received docetaxel and they might be developing peripheral edema. So it might be due to the docetaxel. And then vinca alkaloids are used very commonly. I only listed lymphoma and really, but they're used for leukemias and a lot of different indications. So the very big toxicity, and it's a dose-limiting toxicity, is peripheral neuropathy. So I've had patients who develop a paralysis because they had received so much vinca alkaloids for the treatment of their cancer, and they end up in a wheelchair. So we, of course, want to catch patients before they get to that point, but it is a very effective drug for many cancers. So here we come to our first quiz question. We have our 64-year-old male with colon cancer on treatment with 5-fluorouracil, irinotecan, and oxaliplatin. While receiving therapy, she reports a burning, stinging sensation when she touches the cold metal bar.